Okay. Thank you, Dr. Sumita and AIOC for giving me this opportunity. I think most of what I wanted to cover has been covered, but I just present cases. I think we never get short of cases, so let us just discuss cases and what each one of us has done. This is a lady who's an advocate. She came to me that no medical records of surgery, diplopia in side gazes, but not in the primary position. She was twice operated outside. She says first for the exotropia. She said she had exotropia, and after the first surgery, she said the eye went out more. So again, the surgeon explored, and that's how then she said, again, I felt that nothing was done, and this is what she presented with. So she had basically, this is my orthoptic sheet, and she had basically left there was a exotropia with a hypotropia. And this hypotropia was increasing, so it was same in each gaze. The funny thing was that she had a limitation of adduction in the right eye and limitation of depression in the right eye. I could not see any scar in the right eye, but she categorically said that she was not operated in the right eye at all. I could see only scars in the left eye. So I said, let's go inside and check. That was maybe the nasty thing which I did. if I have to say nasty. I said, okay, let's go in and explore. I don't know anything what is happening. So I said, let's go to the left eye first. I don't have the video, but we'll have to believe what I did. So left eye exploration done. So IO, no adherence, not touched. Lateral rectus was already recessed, 9 millimeter, lot of fibrosis. And I said, okay, I'm not going to touch in again to the lateral rectus because it was already recessed and already a lot of fibrosis. Medial rectus, I could not even open up the conjunctiva. Could not make out what was done to it. So I said, oh God, I have 50 prisms of exotropia. I have to treat my hypotropia, and I could not do anything in the left eye. So, and the patient is a lawyer. No, but she would not sue me at least. So, yeah, no, that I made very clear to her, that you can't sue me at least. I'm trying to help you. So I've said, okay, let's leave the left eye. I can't do anything. So I went to the right eye, and I said, okay, I did a right eye inferior oblique anterior transposition. That was the only thing which was left. With a right eye lateral rectus recession and a medial rectus plication, because I thought even her medial rectus was resected some amount. That's why maybe the small amount of adduction deficit, and so I did plication because I said, okay, that will give me a better result. And she was much better, so she could not sue me, and she was very happy. But not always it's like this. So this is another patient operated by Kali and referred as limitation in movements, both elevation and abduction, and in ophthalmos of the left eye. Basically, left exotropia was large angle exotropia, 70 prisms with a 40 left hypertropia. The measurements, everything was fine because there was only 7 left hypotropia left surgery and only an ET of 6 prisms. So nothing went wrong, but the patient says, I look very ugly. Like my eye is looking small, and I want my eye to look same. So that was the only reason why it was referred to me. Said that, okay, you counsel, because otherwise I've done the right job. They have corrected most of the hypertropia, and I've done most of the exotropia correction. The eye is straight with an esotropia of only 6 and left hypotropia of 7 prisms. So so I said, then this was her pre-op pics which are sent to me. So it was a clear-cut case of 70 exotropia with a 40 L/R. The surgical notes which was given to me was, there were both eyes for a 70, 3 muscles done, 9 and 6, which was quite good enough. And a left eye IO recession done, because there was a 40 hyper in the left eye, the left eye IO recession and a right eye IR recession was also done. So altogether 6 muscles touched, but the patient is not happy. I suspected maybe it could be the eye was not moving up at all, and there was a esotropia and a small hypo. I said, okay, maybe it could be fat adherence syndrome, which is caused by disruption of the orbital fat during inferior oblique muscle surgery. The clinical features of fat adherence syndrome are progressive hypertropia of the affected eye, limitation of elevation, especially in abduction, a very positive force duction test, and upper lid retraction. So all these, I found the findings in this patient. So I said, okay, let me go in and see, because the patient was not happy at all. I said, okay, let me try to find out if there was an inferior oblique, if there was an fat adherence syndrome. I would try to release some, the adherence which is there, or operate on the inferior rectus of the left eye, do a small amount of recession of the inferior rectus of the left eye because I was not moving up. Did an FDT of the medial rectus of the left eye and the lateral rectus, and this was what I planned. Okay, I'll go in, do a small medial rectus because small amount of ESO, and I'll just Botox on the medial rectus, not go much, and inferior rectus, if it is tight, I will just do a recession. So this was what I had planned, and this was what I got also. But I did something else. So because when I went in, inferior oblique, there were, in fact, the inferior oblique was quite clean. It was recessed exactly at the place where it was supposed to be. I don't know if this adherence could have been the cause of the limitation, but this is a small adherence. I don't know if anybody has actually can comment on this, if it has to be more. This was very little adherence which I cut. I mean, I don't even think it was causing the limitation. But the other thing which I found was that there was a medial rectus which had been resected, was found to be transposed full width downward near the inferior rectus. So I'm not sure if this was the reason for this. What I would like to discuss in this forum, whether can this shifting full width cause the limitation in elevation of the patient, because this is what we found once, and this is the limitation. So full width, the medial rectus was transposed full width downwards near the inferior rectus. So it was supposed to be resected, and so this was one thing. So so I changed my management and did a left eye medial rectus recess because small amount of esotropia, and upshifted I said I'll just shift the whole medial rectus upwards. Maybe that was a reason. And then Botoxed on the inferior rectus. So I said I will not do a recession of the inferior rectus, it's already too much. So Botox on the inferior rectus. Not very good result still post-operatively. Patient has not followed up. I think she's not very happy with me also. So I don't know if she'll come to any of you now. So be prepared. So any of you she can come. I'm most happy, because there's a small, but I would like to discuss what to do next. Because there is a light eye scleral show. The inferior rectus recession has been done. Maybe that could be one factor which we could tackle later on. Or should I repeat the Botox in the left eye inferior rectus? Already we Botoxed once. Now it is 4 months. She has not come for follow-up, though I've been repeated. I thought before the IOS I could get but I've not been, she didn't follow up. So what I would say is, my only advice I would say is that don't do too many muscles at one time. I don't know if this is practical in our scenario, in Indian scenario, but I think we should stage. And otherwise the surgery was practically very nice, done for all what is required. So I would say that maybe do an inferior rectus advancement. We'll have to do an adjustable because it's only 6 hypo. So I don't, that could be one thing. I'll just present the last case. I don't know if I have time. This is again a case came with already residual hypotropia, around 30 prisms of hypotropia, operated for Browns, that's what the nose says. There was chicken suture done elsewhere, and there was still a face turn to the right. There was 10 exo, and there was a hypotropia of around 30 prisms. So I said, okay, this is a clear cut, so already chicken suture has been done. I'll just do an FDT of the superior oblique. And I planned that I will go and do a right eye superior rectus and inferior rectus for the residual hypo in the right eye. I will not touch the left eye. But intraoperatively, I did the FDT and found that the superior oblique was still tight. So I was tempted that I will not touch now. I'll go back to my superior oblique and see what it is. And superior oblique, when we explored, it showed a nice chicken suture. This chicken suture was there. So I don't know how, I mean, I'm seeing for the first time what are the effect of this. It was there and I just cut it. I just cut the superior oblique, did a total tenotomy. But this must be how it looks, the chicken suture after the surgery, because it was lengthened and it was having the FDT showed that it was still tight. So maybe one of the learnings is keep doing FDT even after you do a chicken suture. I think don't, maybe you'll have to go back and do it again, because if it's tight, I think you should not leave it like that. That's one of the learnings. And I had planned a left lateral rectus recess, but I thought there's an exo. I'm doing a tenotomy. Maybe I'll get a 6 to 8 prisms exo because of my superior oblique tenotomy. And I did the right eye superior rectus recess for the hypo. So this is what I planned. I did not touch the lateral rectus. So post-operatively, I got a negative FDT for the superior oblique. So this is what I did, and a right eye superior rectus recess only I did, and did not touch superior oblique tenotomy, and I did not touch the lateral rectus. Then I felt so bad because after surgery, the 10 exo was there, and the parents were like, "You have still my exo left." Like, they are not bothered about the tight superior oblique, or they are not bothered about the hypo. So they are saying that, okay, now there's still the 10 exo is remaining, and it looks there. So I was like, oh God, the tenotomy has given me no effect. And for surprising, I know the right eye DVD started coming in. It was around 8 prisms. It was not seen before, and right eye showed DVD. So what I did was I just gave glasses. The face turn had gone, but my tenotomy. I gave glasses, which has hidden the at least the exotropia. And so I've decided to leave. There was a right eye manifesting DVD sometimes, but it is because with the glasses, the DVD and the exo is not seen. So I've left it alone, but I don't know what next. So I'll go ahead and do the lateral rectus recess. That's what my plan is. So any comments, any discussion? Because I've got more cases, but I think I'll just leave it like that. But I think the Esposi and Dr. Sumita and Dr. Rishimai all have told me to put this slide for the Esposi, so I have put the slide. So any comments or any Rohit and Ramesh and Sumita, anything which I should do for the second case? Should I repeat the inferior rectus buttocks or right eye advancement of the inferior rectus?
I think,
no, I can't leave it alone. Yeah, give it some time, yeah.
I think it's the second case is just a few days post-op, I think.
Yeah, a few days post-op, yeah. It's 2 weeks post-op, yeah.
Sometimes the DHT, dissociative
Horizontal.
You mistake it for an exotropia, where it's a small exotropia and you decide you do a small resection. It never works. For DHT, your recession should be a large amount of recession. So it's difficult to differentiate between DHT and an exotropia unless you analyze the motility carefully. In DHT, you get some amount of nystagmus and the refixation movement is slow. It's not rapid. Unlike exotropia where the refixation movement is rapid. So you have to differentiate between the horizontal deviation due to DVD and a horizontal deviation due to exotropia. If you don't differentiate, you will end up with these kind of problems.
I think when you do a cover test with both eyes fixing or either eye fixing, you will see the difference in the measurement between both eyes.
Right eye, fixing left
And
eye.
they will have a nystagmus, as you said, a fine nystagmus, not always. They could also have a DVD component, which
Most
could
of
have
them
come
will
in
have
this
DVD.
patient.
Most of them will have DVD.
Yeah.
Very rarely you will have pure DHD.
Yes, correct.
Most of them would have some DVD and some intorsion also. Some intorsional component will be there.
But it's surprising that superior oblique tenotomy didn't cause any effect on the horizontal. So that's what I thought. But
Generally,
Normally,
Unless it's a very
tight,
so
yeah.
you are not going to have a
Much,
significant
yeah.
change on the
Horizontal.
yeah, in brown,
But yes, in congenital.
it's already done once, no? So I
Yeah,
should have done
yeah,
it.
so now it's not so tight. So that although you could see that cut was a little fibrous inferiorly, which you had to release after you had cut but it was still didn't look like that it was that tight. So probably that's.
both superior oblique, if it is tight, especially in Brown syndrome, you will get a lot of effect on horizontal, otherwise not much. Even inferior oblique, when you do a bilateral, it does not give much.
In fact, you have to be careful in congenital exotropes or infantile exotropes where there is superior oblique overaction, because the severe superior oblique overaction or the tight superior obliques are responsible for the exotropia to manifest. Otherwise, moderate exotropes kids would not, they'll be able to fuse. So they are the ones you have to be very careful. You think it's a very large exo in primary case. You plan for superior obliques along with a large LR recessions, and then you land up with a consecutive. So you have to be a little less on the horizontal.
I think there is a role for small overcorrections or undercorrections for prisms as well as for optical corrections like glasses. We didn't discuss it, but you should always keep that in mind also. Especially
And you
in
could
one-
do a lot of decentration of glasses because most of these patients do have
yeah,
refractive
yes.
errors also.
Yeah, so prisms must be considered for small. Up to 10 prisms, you can easily correct it using prisms. Doesn't work for torsion though.
So thank you so much, ma'am, for making me part of this, I can say, legendary cases I saw with Dr. Rohit sir's cases and Suma madam's cases. I mean, I'm not going to have a huge, I mean, for me, I have not done a lot of oblique resurgeries. So I would be concentrating more on preventive aspect of not, going for a resurgery because these are really, they're only the trained people who do oblique muscles. So we don't get a lot of resurgeries. And these are all peculiar muscles. Inferior oblique may be forgiving, but superior oblique is not at all forgiving. So unless we are pretty sure that we are good at it or we can do it and the patient needs it, we should not embark into it. And second thing is less is more in superior oblique. So we should, if the chicken suture was done, it is okay if there is a residual rather than going for a superior oblique palsy, which will create bigger problems. And torsion is very difficult to manage once you do land up into superior oblique palsy. So these are applied aspects of anatomy, and this is what I was saying about preventive aspect of inferior oblique. The dissections are very, very important. Not running. Oh. Video is not running. A photograph आ गया है. Can I use my laptop? यार मुझे मत दिखाओ अब तो कम से कम वीडियो दिखा दो. So this what we do is we try to what I always try to tell is that you hook it under direct visualization and then try to go and take the whole muscle, and once you are holding the muscle, once you have dissected the muscle, try to see whether you can see the sclera behind it or not. So once you cut this particular septum, you try to see between the two hooks if you can see the sclera or not. Only then you are pretty sure that the muscle is complete. Most of the problems normally, as we have discussed now extensively, that inferior oblique is like your mother and it is a fairly forgiving surgery. So most of the inferior oblique surgeries are forgiving if it is completely hooked. Yeah. So it is, jokes apart. So if there is persistent overaction of inferior oblique, there has to be some part which has been left, or you have done little less for what I mean to say is that your surgical dosage is a little less. Hooking is crucial in primary surgery. There have been there is a good article in AJO on multiple bellies or insertion, and a weaker procedure could have been done for a larger overaction. So what is to be done is that if there is a mild to moderate overaction, still there is a persistent of that, you can do an enterization. You can pull it little anterior. Newer insertion can be more anterior, or you can go for if there is a severe overaction, you can go for a nasal enterization. There is no hypertropia. My surgical choice would be myectomy. Now this is when you have slightly overdone the inferior oblique, or you are going for unilateral surgery and you have done inferior oblique enterization. This is basically a co-contraction syndrome, as Dr. Rohit showed one patient where he did a total anteropositioning of total enterization of inferior oblique. What happens is when patient tries to look up, both superior rectus and inferior oblique are contracting. So it is more like a co-contraction syndrome where elevation would be restricted and there will be more of a Y pattern. So there will be very minimal inferior oblique overaction in the adduction, but when the patient tries to look up, there will be a good amount of lag in that. So in some of the patients we have done. I'm a very big fan of adjustable. And all the patients which I was looking, as so many surgeries were done, I would always go for an adjustable. And even for inferior oblique, I've tried out adjustable inferior oblique surgeries. In patients where I do unilateral inferior oblique enterization, I try to keep it like this, and then if there is still a persistent inferior oblique overaction, I will try to pull it back. So it is reverse, not as we do lateral rectus surgery, where if there is some angle or medial rectus where we directly recess depending on the angle. This would be reverse because we are doing enterization. Was it too heavy? okay, so if you do an infraoblique surgery, you are no, not the muscle, the whole dose of going reverse, indirectly proportional to directly proportional. So when you do infraoblique surgery, you try to bring the eye down, and if the eye is still up, you pull the muscle rather than recessing it. It's still heavy. Okay, we'll drop it there. So supraoblique also, we have discussed enough about the personal life of supraoblique. So supraoblique, yes, I was pointing at supraoblique. So now we have hooked the superior rectus and we are trying to hook the supraoblique. And I would show that, supraoblique also, this is only partial muscle which has been hooked and the posterior fibers are still remaining. So we have to go more posterior, but you have to be careful. You have to use a Barbee's retractor. You have to retract and then try to see posterior fibers and hook them. So you can see the vortex vein. It is this here. Here is the this is the vortex vein. So you have see now the whole supraoblique is there. So you see we have made a partial dent in supraoblique. Since we were planning to do a PTSO, it was not much of a problem. We removed those fibers and left 2 millimeter anteriorly. So supraoblique also you have to be careful. Supraoblique resurgeries are very difficult. I was fortunate enough to see video of Dr. Suma madam. She showed a supraoblique chicken suture resurgery. But I don't have a similar video. But fibrosis is a big issue. To differentiate between tendon and fibrosis would be very difficult in superior oblique especially. So in weakening procedures, PTSO or expander may extrude. It can be removed. If it is associated with esophageal scenario, better to go for an infraoblique weakening procedure along with that. If it is very tight, as ma'am showed, you can do a chicken suture. If it is there as a chicken suture, we can remove and do a clean tenotomy, and we can add infraoblique depending on the primary position angle. In the tuck, on-table FDT is a must, and in immediate post-op revision and reducing the amount of tuck has to be done. Late post-op, removal of non-absolved suture fibrosis. If you have done a tuck and patient has come to you after, say, somewhere else he has got operated, we have to do a supraoblique weakening procedure like chicken suture. Harada Ito, again, most of the Harada Itos I do are adjustable, so never had a problem, and they are easily reversible early post-op. So you have to be very careful with Harada Ito because you are doing it purely for torsion. Harada Ito is mainly for torsion. It doesn't give you any significant weakening effect in any of the gazes of supraoblique or even in primary position. So you can do adjustable Harada Ito and see torsion, intra-op, post-op. And as Dr. Guyton used to teach, you can take an indirect ophthalmoscope, see the torsion inside the OT. The only thing is it would be with an indirect ophthalmoscope, so it will be reverse picture of what you will be doing. Fundus pictures can always help, not intra-op, but it can help. So this was, I am just showing that we did a tuck and we tried to do a FDT. The only tip is when you do FDT post-tuck, it should, your eye should be able to go just above the punctum. So that's the take-home messages that the first point has been exclusively dealt with. Torsion assessment both subjectively and objectively is very, very important. This gives you very good clues. A lot of times, you see patients where you feel that maybe I can touch infraoblique. If you look at the torsion, it would become very clear whether this particular patient needs infraoblique surgery or not. Resurgeries are pretty difficult in both the scenarios, but still easier in infraoblique. You can do a myectomy at any difficult case, but would be difficult for supraoblique because you may have to think of supraoblique paresis. Dissection should be slow and gentle in all resurgeries. Cut as little because identification is difficult. Thank you so much. I have not done a nasal myectomy, but I have done nasal enterization. Maybe Ramesh or Rohit. Yeah, I have done nasal transpositions. Above the muscle, above the inferior rectus. Yes, you could very
Nasal transposition is a very, very effective surgery.
Yes.
I'm not very, I would say, daring to do it on pure primary eye.
No, not pure.
I have restricted the IONTs to SOP, superior oblique palsies, and for DVD. So SOP, I feel that it's a very, very good surgery. In fact, it helps us to bring about a little bit of encyclotorsion. There's significant amount of 10 to 12 degree torsional change by IOANT. So that's very good. If the vertical is more in superior oblique palsies, I would think in terms of an iliated Nanking or even a +2 iliated Nanking. If the torsion is more in superior oblique SOPs, then I would think in terms of a anterior nasal transposition, because you get a huge torsional correction.
Torsion difference is pretty significant.
Yes, so you have to. So you don't get significant anti-elevation with the anterior nasal transposition, but then if you have a significant vertical up to, you can correct with the anterior ENN or +2, you can correct up to 20 prisms of vertical deviation. So if you're looking for that, more often than not, most patients have been happy. One patient I can never forget, because she was a basketball player and she was very, very unhappy because of the anti-elevation. But yeah, you will see some amount of anti-elevation. It does get a little better with time, but anti-elevation will happen the moment you start anterior positioning. I'll just mention about inferior oblique resurgery. We've had, unfortunately, to do a fair amount, and initial ones, I actually cut the IR. I started dissecting and I didn't realize it was just adherent to the inferior rectus. I thought I just have the IO, and then I started disinserting. I could see the insertion of the inferior rectus, the insertion line. Obviously, it was a smooth, clean line, so I stopped halfway, resutured the IR back. So again, you have to be very careful in any resurgery. Identify the muscle carefully, particularly IOs, because they start getting adherent to the adjacent muscle.
Can I just make a point about the inferior oblique? One of the problems of operating on inferior oblique is you must use an operating microscope. If you do not use operating microscope, you always end up with difficulties. Some time ago, I presented what is called as a recessing inferior oblique without suture, without hook, inferior oblique recession. I showed the video where you can hold on to the sheath and pull it gradually, hand over hand technique. And when you do that, the inferior oblique presents itself right at the entrance. Once you had as presented at the entrance, then you go back and catch the posterior part of the inferior oblique. This I learned from while working with John Lee. He's unfortunately no longer there. So what it is you don't need to see the white at the back. Once you don't have to always see the white. If you see the white, you are right, he said. Not always, I said.
I think we are running out of time. She's showing the message to conclude. So thank you. So thank you all for attending, and I hope everybody it was an educative experience for everybody. Thank you.